Yeah, it's visible to everyone.
Okay, ma'am. Add this.
First, Aishwarya, you are presenting or Dr.
Yes, ma'am. I'm presenting, ma'am.
So you're going to go ahead, okay? That's okay. You
Sure.
can start. Yeah.
Okay. So, very good evening to all the respected faculty and my dear co-fellows. The topic for discussion today is ultrasound guided thoracic and lumbar spine and the paravertebral block. Just a second.
Why do we need a spine scan now?
Sorry, just a second.
Take your time. We are not in a hurry.
Yeah. So before we dive into the plethora of this topic, what question comes in my mind is why do we need ultrasound guided spine scan at the first place? So there are various studies which has depicted that the anatomical landmark, that is the Tuffier's line, which is said to correspond to L4, L5 level, is misleading in more than 30% of patients, and it usually corresponds to a level higher than expected. There are many studies comparing the landmark technique and the ultrasound guided technique, like a study here by Sheriff et al. That ultrasound guided intrathecal anesthesia does scanning help. And they concluded that the pre-procedure ultrasound scanning improved the first needle attempt success rate, decreased the redirection of further attempts, and gave better patient satisfaction. USG not only increases the incidence of successful first pass in normal healthy individuals, it also assists in cases like obesity, spinal deformity, and previous spine surgeries. To support this point, there was a study done by Sir Kijin Chin. The ultrasound imaging facilitates spinal anesthesia in adults with difficult surface anatomical landmarks. Here, they took the patient with BMI more than 35, patient with poorly palpable spinous processes, moderate to severe lumbar scoliosis, or previous lumbar spine surgeries. And they concluded that the pre-procedural ultrasound enhances the performance of spinal anesthesia in non-obstetric patient population with difficult anatomical landmarks, and first attempt success rate was also twice as high in the ultrasound group than in the landmark group. Similarly, a study which was done to see the ultrasound assisted technique versus conventional landmark technique in class 3 obesity patient, and they also concluded that the pre-puncture ultrasound assisted technique increased the success rate at the first attempt in pregnant women with class 3 obesity. Therefore, pre-puncture ultrasound imaging in spinal anesthesia is useful for patients with class 3 obesity whose anatomic landmarks are unclear in conventional landmark palpation. So what are the benefits of scanning? By scanning, we can know the midline. We can get to the level where we want to inject. We can know the interlaminar space, the depth for the needle insertion, the angle and the direction in which we will insert the needle. It will reduce complications like vascular puncture, headache, backache. And also in case of anomaly, it helps us prepare better. Now coming to the first topic, lumbar spine. So these are the indications for the spinal and epidural, as we all are aware, like surgical procedures in abdomen, pelvis, lower limb, labor analgesia, for lumbar puncture, and for post-op pain relief. And the contraindications are patient refusal, infection at the site of injection, any coagulopathy, severe hypovolemia, sepsis, any demyelinating lesions, and so forth and so on. So before I start with this topic, I would like to familiarize everyone with the basic anatomy of the lumbar spine. So this is a single lumbar vertebra. This is the vertebral body. I hope my pointer is visible. This is the vertebral body. This is the pedicle, the transverse process, and these are the lamina and the spinous process. These are the two vertebrae in the lateral view, vertebral body. And as we can see, this is the spinous process. This interspinous space is important. Coming to the posterior view, we have two vertebrae. This is the interlaminar space. So when it comes to ultrasound scanning, this interspinous space and the interlaminar space are two very important spaces. So typical and atypical lumbar spine. So L1 to L4 vertebra are the typical vertebrae and L5 is called the atypical vertebra. Why so? So if we look at the L5 vertebra, the body of the L5 is largest when we compare to L1 to L4. Then secondly, the transverse process, as we can see here, the transverse process of L5 is short, thick, pyramidal, and it is attached to the entire thickness of the pedicle. The spinous process of L5 is relatively short, and the inferior articular process of L5 is at a larger distance compared to the superior articular process of L5, and it is reversed in the other four vertebrae. Also, the inferior vertebral notch is deeper in typical lumbar vertebrae compared to the L5 vertebra. So once we are familiarized with the anatomy, we'll see the anterior complex and the posterior complex, because they form a very basic for the scanning of spine. The anterior complex is a single hyperechoic line which is formed by the vertebral body, the posterior longitudinal ligament, and the anterior dura. Since there is a bony structure present, so the ultrasound waves will be reflected back. Hence, it is visible. Anterior complex are more or less always visible in a normal individual. Coming to the posterior complex, it is single and sometimes double hyperechoic line can be appreciated, which is formed by the ligamentum flavum, the epidural space, and the posterior dura. So when we are injecting in a midline approach, the structures which we will be piercing will be skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, then comes the ligamentum flavum. As we cross it, we reach our epidural space, and as we cross the dura, we'll reach our subarachnoid space. And if we are going by a paramedian approach, we will be surpassing the interspinous and the supraspinous ligament. Coming to the sonographic views. So here in spine scan, we'll be using a curvilinear low frequency probe. This will be my setting. I'll be using curvilinear probe. Spine will be the exam setting. If we don't have spine setting, we can even use MSK mode. Our center line should be on and the penetration mode should be on. So coming to the views, for the scanning, we have three parasagittal views. First is the transverse process view. As we can see in the diagram on my right of the screen, if the probe at the A position is the transverse process view. Now, if I slide the probe medially at the B position, it will be articular process view. And at the B position, if I insinuate my probe medially, I'll come at the oblique or the interlaminar view. And then there are two transverse views. At position A of the probe, we have the spinous process view, and at the B, we have the interspinous view. So these five views are important. So now coming to each view one by one, parasagittal transverse process view. So as I told, our probe will be at position A. This is on the spine. And what we will see, we'll see a hyperechoic line followed by an acoustic shadow. It is looking like a trishul or a trident, hence the name trident sign. Next will be our parasagittal articular process view. Now the probe will be at position B. So what we'll see is a continuous hyperechoic line resembling an camel hump appearance. Now at the position B, we will insinuate our probe medially. So we'll come at the parasagittal oblique or interlaminar view. Here, what we'll see lamina, which are horse head appearance or a sawtooth appearance. We can make out the anterior complex. We can make out the posterior complex. Sometimes when we see two hyperechoic lines at the posterior complex, we can actually make out the epidural space. And in between the complexes, we can see the intrathecal space. With this view, we mark the level. At what level we want to give the spinal anesthesia or epidural. Now, the sequential scanning. As I scan medially, see this is the transverse process. As I go medial, the continuous articular process. And as I insinuate, we'll get the interlaminar view, the laminas. Moving forward to our transverse spinous process view. The probe position will be at A. What we will see is a spinous process followed by an acoustic shadow and two laminas. It is the tower sign. Then we'll go to the transverse interspinous view at the position B. Here, we can see the cat eye sign. That is, we'll see the anterior complex, we'll see the posterior complex and the articular process. With this, we can identify the midline and also the depth at which we will find the intrathecal space or we can find the epidural space. Now coming to pre-procedural ultrasound assisted neuraxial scanning and marking. So how we will go ahead with the spinal anesthesia or epidural anesthesia. First, we'll scan the level. I'll be counting from downwards. This is my sacrum, S5, L5, S1 space, L4, L5 and L3, L4 space. Once I reach the L3, L4 space, I'll mark this space for the level. So as I have reached my L3, L4 space, how do we know we have reached it? We have counted from below and now we can see the intrathecal space in between. We have the anterior and the posterior complex. Our center line is on. So in the midline, we'll just mark the Mills line. That is the midline of the interlaminar space. Once we have marked the midline, we'll turn the probe 90 degree. And we will angulate the probe as we can see in the middle figure, that if the probe is straight, the rays might not pass or reach the intrathecal space. There is little curvature. So to make our rays pass through the intrathecal space, little angulation is needed. And we should keep in mind the angle, at what angle we are holding the probe while we are taking a prick. So in this position, what we can see is the anterior complex, posterior complex, the intrathecal space. Now we'll take the depth. For the spinal anesthesia, we'll take the depth from the skin to the intrathecal space. And for epidural, we'll take it to the posterior complex. Once I have done the marking, I'll join these 2 points. And this will be my point of insertion of the needle for the midline approach. And keeping in mind the angle in which I got the transverse interspinous view. Now the paramedian approach it's similar. What we'll do in this, we'll hold the probe in the paramedian sagittal oblique view. From here, we'll make a horizontal line, and from the midline of the probe on the long axis, we will make a vertical line. This will be my ultrasound view of the parasagittal oblique interlaminar view. So now I'll be joining both the lines of the long axis and the short axis, and this will be my point of paramedian approach with the angle with which we have held the probe here. So we need to keep in mind the angle in which we got this image. So just to compare, this is the midline approach and here it will be the paramedian. Now a new approach, that is the paraspinous approach. In this approach, what we'll do first, we will draw the Mills line. That is the midline of the interlaminar space with this view. I got the midline at what level I want to give. Then I will turn my probe and I will come at the spinous process level. I'll draw a line at a spinous process of the below level and the above level. Once I have drawn that, where will be my needle point of injection? I'll inject 0.5 centimeter lateral and 0.5 centimeter caudal to the lower spinous process. Sorry, cranial. I'm really sorry. 0.5 centimeter lateral and 0.5 centimeter cranial to the lower spinous process. This will be my angle of injection. And this will be my point of injection. And my angle will be 5 to 10 degree lateral to medial angulation with cephalad tilt, as we can see in this diagram. So this approach will be for the paraspinous approach. So we did it and successfully we got the CSF. So now just a comparison between paraspinous and paramedian. As we all know that in paramedian, our position of pricking is approximately 2 centimeter lateral to the midline. And in paraspinous, as I told, it's hardly 0.5 to 1 centimeter maximum from the midline. So as we can see in the compass here, the arc of guesswork will be less if it's in paraspinous and the arc of guesswork is more in paramedian. Also, the footprint of the probe which we are using is large and angulation also has to be kept in mind. Hence, paraspinous approach has little more advantage over the paramedian approach. Because in paramedian, the guesswork is too much. We might be hitting anterior process. If we can articular process, we might hit the spinous process. And in paraspinous, the guesswork is less. The paraspinous versus midline, it has been seen that in paraspinous approach, there is less incidence of backache. Why so? Because in paraspinous approach, we are bypassing the supraspinous and interspinous ligament. And it is said that the backache usually arises because of the tear in those ligaments. And there will be less incidence of PDPH also in the paraspinous approach because of the angulation of the needle. The rent which is created in the epidural space, in the dura and the ligamentum flavum, they will form a flap-like structure, hence less incidence of PDPH in paraspinous when we compare it to midline. So at what place is the paraspinous helpful? Paraspinous is helpful in patient like in hip surgery patient where we are not able to give an optimum position while the spinal, because the width of the paraspinous interlaminar space will be minimally affected by flexion of hip or lumbar spine. So even if the position is not good, we can go with the paraspinous approach. It's helpful in obese patient. It's helpful in scoliotic spine also. Now coming to a paramedian diagonal or cross view. This view is generally used for USG guided real-time or USG real-time assisted spinal. This will be my probe position. So when I keep my probe in that position, what I'll see is I'll see the spinous process of L2 and I will see the lamina of L3. As you can see in this ultrasound figure here. This will be my end trajectory of the needle. I'll go in plane from caudate to cranial like this and I'll reach my intrathecal space and inject. Just some articles over the real-time ultrasound guided versus ultrasound assisted spinal anesthesia. They concluded that the success that ultrasound assisted technique they concluded that the ultrasound real-time technique is not superior to the assisted technique because the real-time technique has lower success rate, longer procedure time, lower satisfaction score, and it is more difficult to perform. Also, in a study where they compared the real-time ultrasound guided spinal with the pre-procedural ultrasound guided spinal in obese patient. In obese patient, in this study, they found that the real time was superior to pre-procedural scanning because since the patients were obese. So depending on the scenario, we can decide what modality, how we want to proceed. Now coming to some of the abnormal spines. So this was a patient of ankylosing spondylitis. As we can see in the MRI or in the X-ray, there is hardly any space. On ultrasound imaging also, no space was visible. Only L5S1 space was the space which was visible and we gave the drug here. So L5S1 space is actually an underrated space and can be helpful and very much helpful in such scenarios. This was an obese patient. In this patient, the anterior complex and the posterior complex both were not visible. So if we encounter such cases, what we can assume that where the transverse process is lying, the anterior complex will lie somewhat at that same level. So like in this image, the complex was lying at around, we assume that the complex was lying around 5 centimeter and our CSF flow came at around 5.1 or 5.2 centimeter. So this is a scoliotic spine. So we have to identify the direction of the scoliotic curve. It will be opposite. The curve of the scoliotic spine in the lumbar region will be opposite to the thoracic region. There will be axial rotational deformity. So basic point is like whenever in a scoliotic spine, as we can see in this diagram, the convex side of the spine will have a wider interlaminar gap compared to the concave side. So we need to identify the direction of the scoliosis and we should approach our needle from the convex side so that we can get a wider interlaminar space. I'll hand over to Dr. Suma.
Good evening, everyone. Coming to thoracic spine. So what is the differences between thoracic and lumbar vertebra? In thoracic vertebra, the body of the vertebra is smaller in comparison and the articular process are situated anterior to the transverse process, and the body and the tip of the transverse process, they have extra articulations for the rib facets. And coming to the lamina, in the lumbar vertebra, the lamina has interlaminar gap, whereas in thoracic vertebra, the lamina are crowded, and are overlapped. And this is a posterior view of the lumbar and thoracic vertebra. We can see the overlapping lamina, and the spinous process is posteriorly and inferiorly angulated, and hence midline approach is difficult in thoracic level. And So coming to thoracic vertebra, there are 12 thoracic vertebra, and there are morphologically varies throughout. So coming to thoracic vertebra from T1 to T4, they are morphologically similar to cervical vertebra. Here the articular processes are vertically oriented. Coming to vertebra from T9 to T12, they are morphologically similar to lumbar vertebra here, but the interlaminar spaces are comparatively narrow. Then coming to vertebra from T5 to T8, these are the typical thoracic vertebra. Here we can see the extreme inferior angulation of the spinous process, and the inferior border of the spinous process, it almost covers the mid laminar level of the inferior vertebra, and this transverse process are located posterior to the articular process, and it has articulations for the rib. So what are the indications of thoracic epidural? So thoracic epidural is helpful. It can be used as an adjunct to general anesthesia, like in cardiac surgeries and upper abdominal surgeries and thoracic surgeries. Also, if where the general anesthesia is contraindicated, we can use as a sole anesthetic also. And it also useful in pain procedures in cases like fracture ribs. So the contraindications will be same as Aishwarya described before. What are the uses of ultrasound, uses of epidural? Epidural helps in improving perioperative analgesia compared with other modalities. It reduces the postoperative pulmonary complications. It also reduces the duration of postoperative ileus, and it also decreases the duration of mechanical ventilation, and it also helps in reducing the mortality in patients with rib fractures. So why do we need ultrasound? So there are many studies has been done on ultrasound guided thoracic epidural. Of that, in one observational study done by Karuna et al., where they have used real-time ultrasound guided thoracic epidural placement, and they have concluded that successful epidural placement was achieved in every patient, and all catheters were found to be effective for use in the post-operative phase. And there is one more study done by Park and Gulati. They have done ultrasound assisted thoracic epidural, and they have succeeded in placement of epidural catheter in all the patients. And there is one more study done by Grau et al., and they have compared the ultrasound picture with the MRI, and they have concluded that pre-procedural ultrasound, it facilitated successful catheter placement. So all these studies shows that ultrasound guided ultrasound is very useful in placing the thoracic epidural as well as in lumbar epidural, and it also helps in reducing the number of punctures. So what is the role of ultrasound assistance? So ultrasound helps in identifying the desired thoracic level for epidural insertion. It also helps in identifying the midline to identify the interlaminar space and depth of the lamina. It also helps to mark the needle insertion point. It also helps in getting rough estimate of skin to epidural space distance. So what are the ultrasound views we are going to discuss? As described by Chin, there are 7 views in the thoracic epidural: paramedian sagittal costal view, paramedian sagittal costo transverse junction view, transverse process view, articular process view, oblique view, paramedian diagonal or cross view, and transverse view. Vertebral level. Now now what I can see, this is the rounded hyperechoic structure with the acoustic shadow. This will be my rib. On the other side of the rib, the hyperechoic, this line will be my pleura. So this is the parasagittal costal view. And coming to, if I move my probe medial to the costal view, now I can, so my probe is at this level. Now what I can see the transition between the rib and the transverse process. So here we can see the step up. So this is also called step up view or paramedian sagittal costo-transverse junction view. So if I move my probe more medial to the costo-transverse junction, now my probe is at the level of the transverse process. So here we can see the transverse process as a hyperechoic structure with an acoustic shadow. This is a paramedian sagittal transverse process view. If I move my probe more medial to the transverse process, now my probe is at the level of the articular process. Here this is the paramedian sagittal articular process view. So from here, if I tilt my probe inside, now I can see the interlamina. So the difference between the lamina in the lumbar and the thoracic region is here the lamina are flat, whereas in lumbar vertebra we will see sawtooth lamina. So this view is important for us because we have this helps in identifying the interlaminal space. It also helps in getting the skin to a laminal distance. So from there, if I rotate my probe to 90 degrees, now my probe is at the level of the spinous process. So this is the transverse spinous process view. Here I will see the spinous process with an acoustic shadow. This is the lamina and this is the transverse process. Now coming to rib counting. So here I have used high frequency linear probe because my patient is thin built. We can use low frequency curvilinear probe also. So here I have placed my probe at the highest point of the shoulder. So from there I will get the rounded hyperechoic structure, which will be my second rib. So if I slide my probe more medially, I will get the first rib. So from there I will count down until I will get the desired level. From then, after I get the desired, I will reach the desired level. From here, I will do the sequential scanning. So I will start moving my probe medially. So first I will get costal view, then costal transverse junction view, then transverse process view, then articular process, and I will come to the laminar view. So coming to ultrasound assisted epidural space identification. In the paramedian sagittal oblique view, I will get the interlaminar view. This is the interlaminar view. So here my probe, from the center of my probe, I will make my one horizontal marking on the patient. After that, I will rotate my probe until I will get this spinous process view. Here I will place one vertical marking. So then I will join the two lines. So from this point of intersection, 0.5 centimeters lateral and 1.5 to 2 centimeters caudal is the site of needle insertion. So this will be the site of needle insertion. So and my angle of insertion will be 5 to 10 degrees lateral to medial and 50 to 60 degrees in the cranial angulation. So from this we can get rough epidural depth also. So from the skin, it will be measured as distance from skin to lamina plus 2 to 2.5 centimeters. So coming to real-time ultrasound thoracic epidural, this was described by Karmakar et al. In this here, the patient was placed in lateral position after standard ASA guidelines and pre-anesthetic evaluation. After sequential scanning, so they have, ma'am. Yes, ma'am. Hello.
Suma, your slides are,
ma'am, your voice
they are
is breaking.
lagging
Yes, ma'am.
behind. Yes, your slides are lagging
Yes, ma'am.
behind. Your slide, when you talk, the previous slide is still on. Something wrong. So just check.
Yes, ma'am. Okay.
Yes, ma'am.
Ma'am,
Suma,
is it visible now?
Stop sharing and start resharing.
Yes.
Okay, sir.
Stop the sharing and start
Yes,
restart.
sir. Yes, sir. Can you connect to this thing? Connect yourself. On now? Yes. Okay. Connected. Okay. We'll share again. Is it visible? Just a second. good. It came from.
Yeah,
Yes,
it's visible
can-
now.
Yeah, we can see
Okay,
your
ma'am.
screen.
I'll just get to that side. Sorry for the inconvenience.
No, you can start from the sequential counting. You know that from that
Okay,
slide you
sequential
can start.
counting you start.
Yeah.
Yeah. From here, ma'am, sequential scanning with the
Yes.
rib counting. Okay.
So coming to the rib counting, I have placed my, I have used high frequency linear probe since my patient was thin built. We can use low linear probe also. So I have kept my probe on the highest point of the shoulder. Now I can, so what I can see. Now the structure which I am seeing is my second rib. So if I go slide more medially, then first rib will come in the picture. So from there I will scan down until I will get the desired rib level. So from here I will do sequential scanning. So from after I reach the desired vertebral level, then I will slide my probe medially until I'll get from costal view to transverse process view. I'll come back and this is my costal transverse junction view. Then this is my articular process view, and this is the laminar view.
Uma, there is
So
still lag.
coming to
Check your internet.
ultrasound assisted epidural space identification. So after I have reached a
Suma, there's still lag, huh?
Check your
Uh,
internet again.
It has stopped. I
Yes.
think it was from the Aishwarya's account. Now Aishwarya has also left, so it has stopped.
Yeah, the screen is gone.
Issue.
I'll- Dr. Aishwarya, am I audible?
You need to call.
I will just call them. Just 1 second.
Hello, are we audible?
You are audible, Aishwarya, but we cannot see your screen.
Yes, ma'am.
Take your
Is it-
time. There's no hurry. It's okay.
Is it visible, ma'am?
Yeah, your screen is visible. You might again have to go to the sequential scanning.
Yes, ma'am.
First, check your video and then start explaining.
Sequential scanning. Yeah.
Yeah, check the video and then start explaining. We'll wait.
Yes, ma'am. Video control is working.
Your screen is again gone, doc.
Yes, ma'am. Yeah,
Your
sequential.
screen is here. Just make it full screen and check the video.
Yes, ma'am. Yes, ma'am, it's running. Okay.
Okay, so you can restart.
Yes, ma'am. Sequential scanning. Yeah. Yes.
So after I reach my desired vertebral level, then I will do my sequential scanning. So I will slowly slide my probe medially. Junction view after coming back from transverse process. Now this is my articular process view, and this is my laminar view. So coming to ultrasound assisted epidural space identification. So from the from the pyramidal sagittal oblique view, I will get the desired interlaminar view level. Here I will mark one horizontal line on the patient. So after that I will rotate my probe to 90 degrees. Then I will get the spinous process view. Then I will mark one vertical line. So I will intersect the both the lines. Then from that point, so 0.5 centimeters lateral and 1.5 to 2 centimeters caudal is my target of needle insertion. So The angle of insertion will be 5 to 10 degrees lateral to medial, and 50 to 60 degrees cranial to cranial angulation. So the rough epidural depth will be from the skin to lamina distance plus 2 to 2.5 centimeters. Coming to real-time ultrasound-guided thoracic epidural, this technique was described by Karmakar et al. In one of the articles. Here, the patient was placed in the lateral position after standard ASA monitors and pre-anesthetic evaluation. So after the sequential scanning, after getting the desired interlaminar level, the skin was infiltrated at the caudal end of the ultrasound probe. So this was done in the pyramidal sagittal oblique view. So this is a pyramidal sagittal oblique view at the interlaminar level. The skin was infiltrated at the caudal end of the ultrasound probe, and the needle was inserted in plane in caudal to cranial direction until the needle tip was seen to lie adjacent to the target interlaminar space. So once Tuohy needle was judged to engage in the ligamentum flavum, the probe was removed and loss of resistance syringe was attached, and the procedure continued. So there is one more view called pyramidal diagonal or cross view, and this technique was described by our Shiva sir by real-time ultrasound guided mid-thoracic epidural placement by pyramidal diagonal or cross view and drip infusion technique. So in this technique, the patient was positioned prone. Here the target level was taken as T4 to T5 intervertebral level. After reaching the desired level by rib counting and sequential scanning in the pyramidal sagittal oblique view, so the T4 and T5 vertebra, the T5 lamina has kept in the center. From here, the probe was rotated 20 to 30 degrees clockwise if I'm scanning in the left side, or anti-clockwise if I'm scanning in the right side without any tilt. So now we can see the transition of this T6 T6 lamina to transverse process, and the T5 lamina is there, and transition of the T4 lamina to spinous process, base of the spinous process. Then the needle was inserted in plane from caudal to cranial direction. So once crossing the T5 lamina, the needle tip won't be able to visualize because of the because of this bony shadow. And it is then the probe was taken out, and by the tactile sensation of the operator, and from there the stillet was removed, and IV drip set which was primed with 0.9% normal saline was connected, which was hung 60 centimeter above the level of the operating table. So then the loss of resistance was identified by giveaway field and also the free flow of saline. Once we get the giveaway field, the saline was disconnected and loss of resistance syringe was attached, and position was reconfirmed again with 2 to 3 ml of saline, and the procedure continued by threading the epidural catheter.
Okay, so Aishwarya this side. I'll be continuing with the last topic of today, that is the ultrasound guided paravertebral block. So paravertebral space is actually a wedge-shaped space. Now I would like to have everyone's attention on this figure. It's a beautiful 3-dimensional figure depicting the boundaries of the paravertebral space. It is anterolaterally bounded by the parietal pleura. The base is formed by the vertebral body, the intervertebral disc, and the intervertebral foramina. The posterior wall will be formed by the superior costotransverse ligament. As we can see in this figure above, the SCTL extends from the lower border of the transverse process above to the upper border of the transverse process below. Then there is endothoracic fascia, which is actually present between the parietal pleura and the SCTL. And this fascia divides this paravertebral space into 2 compartments, the extrapleural compartment and the subendothoracic compartment. So what are the contents of the paravertebral space? We have intercostal spinal nerves, which are divide of the facial sheath. Hence, they are exceptionally susceptible to the local anesthetic. Then there is dorsal ramus, intercostal vessels, rami communicantes, and the sympathetic chain. This sympathetic chain lies anterior to the endothoracic fascia, and rest all the structures are present in the subendothoracic plane. So what is the mechanism of spread of the local anesthetic? Once we inject, the local anesthetic can be localized to the level where we have injected. Also, it can spread to the level above and below. Laterally, if we see, it can go to the intercostal space. Medially, it can extend to the epidural space. And also, there's a concept of extended unilateral anesthesia. If we give thoracic paravertebral block at a lower level, posterior to the endothoracic fascia, then the spread will occur inferiorly via the medial and the lateral arcuate ligaments. And the drug will then reach the retroperitoneal space where our lumbar nerves lies. So for this, we'll be using the curvilinear probe, or also we can use the linear probe depending on the habitus of the patient. The indications, as we all are aware, for anesthesia, for breast surgery, herniorrhaphy, for analgesia, for breast surgery, thoracic surgery, cholecystectomy, appendicectomy, for acute and chronic pain management, CRPS, and so on. So coming to the sequential scanning, first our probe will be at the position 1, where we can visualize the spinous process. Now, after this, we'll slide our probe laterally. We'll reach the costotransverse junction, point 2. Then we'll slide it quadad. We'll reach the articular process view, and we'll slide off the articular, we'll reach the transverse process view, and we will slide off the transverse process view to reach the articular process view. So this is my position 1. I can see the spinous process and I can see the laminas. It's a flying swan sign. Then I'll slide my probe laterally. I'll reach the costotransverse junction. This is the rib and this is the costotransverse junction. As I slide caudad, I can see the transverse process. I can see the superior costotransverse ligament. The pleura will come into picture, and this will be the apex of the paravertebral space. And as I take my probe to the 4th position, that is the articular process side, we can see the pleura, we can see the SCTL ligament, and we can beautifully see the thoracic paravertebral space. So in this video, we have depicted in-plane needling using a linear probe. My needle is coming, piercing the intercostal muscles and the superior costotransverse ligament. Once we start injecting the drug in the space, we'll see the pleura is dipping down. Also, we have put a curvilinear probe, in-plane needling from lateral to medial direction using a curvilinear probe. This is my pleura, this is my space, this is the SCTL ligament. My needle is coming in plane from lateral to medial side. It's piercing the muscles and the superior costotransverse ligament. And once it reaches the thoracic paravertebral space, the pleura will be dipping down. So what are the complications of thoracic paravertebral block? There is proximity to the pleura, so there are chances of pleural puncture. But mind you, there are some articles which I would like to quote. There's an article by Adam et al. Which said that complication rate of ultrasound guided paravertebral block for breast surgery, and they concluded that the pneumothorax following a non-continuous ultrasound guided thoracic paravertebral block using a parasagittal approach was similar to the rate to the pneumothorax following a breast surgery. Also, in a nice article by Dr. Karmakar, he concluded that the inadvertent pleural puncture is uncommon and it may or may not result in a pneumothorax, which is usually minor and can be managed conservatively. And if it does occur, pleural puncture can be converted to interpleural analgesia. So yes, pneumothorax is a complication, but that should not be a hindrance or a stigma to go ahead with the paravertebral block. Some other complications are the epidural or the intrathecal spread, ipsilateral or bilateral Horner syndrome. So now this takes me to my second topic, like what will be the number of injections and at what all level we can inject. So this study by Zoher et al., they said that the main finding of the present study was that multiple paravertebral level injections resulted in more reliable radiographic and clinical distribution when compared with a single injection technique. Also, another study where they compared a single level with multi-level unilateral thoracic paravertebral block in patients undergoing MRM. And here also they concluded that a multi-level technique of administering the thoracic paravertebral block is a better choice for providing a standalone intraoperative anesthesia and postoperative analgesia in patients undergoing MRM. So there have been different approaches to the thoracic paravertebral block, which has been documented, as we can see in this figure. In the transverse position, the ultrasound can be placed at the level of rib, at the level of transverse process, and or at the inferior articular process. And there are different approaches to the needle path. Similarly, for the sagittal, we can place the probe at the rib level or the transverse process with different approaches to the needle path. So there was a study in which they compared different approaches. They compared loss of resistance technique with the ultrasound technique, and in the ultrasound technique, 3 approaches. That is the sagittal, the transverse in-plane needling, and the transverse out-of-plane needling. They concluded, of course, the ultrasound technique was superior to loss of resistance technique, and amongst these 2 ultrasound technique, they concluded that the sagittal ultrasound approach was most successful. Contrary to this, there was a study in which the transverse versus parasagittal in-plane approaches were compared, and they said that there was no clinical significant difference seen for continuous ultrasound-guided thoracic paravertebral block using a microconvex probe, and both the approaches achieved a high rate of correct catheter placement. This is a very recent study of 2025 in which they have done a cadaveric study to compare the spread of the drug in the transverse versus sagittal in plane. So they gave the injection at T6, T7 level on 5 cadavers. And what they observed was that both the transverse and the sagittal ultrasound guided approach reliably targeted the paravertebral space, and there was no significant difference observed between the 2 approaches regarding the number of the segments stained or the intercostal spread area and the percentage of the sympathetic chain stained. Hence, to conclude that there are different approaches, but the approach which one wants to go ahead totally depends on the discretion and the comfort of the anesthetist performing the block. So as we conclude our slide, we'd like to give some tips that the scout scan is important, and to recognize the abnormal, it is very important. We should know what normal looks like. We should always keep in mind the angle of the probe in the transverse interspinous view before taking the prick. Sitting is easier than the lateral position. Paramedian paraspinous approach is best in elderly arthritic spine. Transverse view is best to identify the midline in obese patients. Needle tip should always be visible in paravertebral block since pleura is very near. And last trolley should always be ready. These were our references. Thank you for your patience.
I must congratulate both of you, Dr. Suma and Aishwarya. That was extensive presentation and excellent slides and excellent delivery.
Thank you, ma'am.
Yeah, it was really, credible. I just wanted to ask you one question.
Yes, ma'am.
It's very simple. What dose do you routinely use if you are doing a single shot paravertebral block?
Okay, ma'am. So, ma'am, depends if we are using it for anesthesia purpose or for analgesia purpose, ma'am. Mostly in our institute, we use it for analgesia purpose. For that, we are using 0.2% ropivacaine, ma'am, and we generally inject around 20 to 25 ml in the space, ma'am.
Correct. And how many levels you are targeting?
Ma'am, what we have observed is like 2 levels above or 2 levels below is the spread only, ma'am.
Correct. This is what I wanted to. So when you put your needle, it is at the center of the level, isn't it? What
Yes,
level
ma'am.
you want to
Yes,
start,
ma'am.
and the spread will be up and down.
Yes, ma'am.
Beautiful. And have you been doing the paraspinal approach of spinal or epidural routinely?
Yes, ma'am, not very routinely. We mainly go to the by the midline approach, but if we have some difficult spine, as we can do on the scout scan, we get to know the spine morphology. Then accordingly, we go with the paraspinous or a paramedian approach, ma'am.
Correct. You have beautifully depicted what the difference between the paramedian and the paraspinal,
Thank
and
you, ma'am.
it's the approach something everyone should be following it actually whenever indicated. Yes.
Thank you, ma'am.
Any complications you have seen when you are doing any ultrasound guided spinals or epidurals? Any
No, ma'am.
practical difficulties?
Practical difficulties, yes, ma'am, because what I have faced that when we generally do, ma'am, ultrasound assisted, not the guided technique. So when we
Correct.
are putting the probe and we ask an assistant to mark, there is sometimes the patient might move. By the time we are washing up and we cannot rely completely on our marking, sometimes there
Correct.
could be some changes in the patient positioning. So it is an assisted, but yet we are going blindly after even seeing on the screen. So we need to picturize the internal anatomy, ma'am. Like if we are hitting the needle on a very superficial surface, then I know that I might be hitting the spinous process. Or if on the deep, if I'm hitting, I know that I might be hitting the lamina. So accordingly, I can change my angle of the needle. And if I'm hitting the lamina, I can walk over the lamina and reach my space now.
Correct. So just a small tip, whenever you are doing the marking in both the planes, like the transverse plane and the sagittal plane,
Yes,
you
ma'am.
should extend those midline marker, whatever marking lines you are putting, just extend it a bit on both the sides, so that whenever you clean your back also, the outer parts of these lines are still there, and you can
Yes,
continue to
ma'am.
imagine the
Yes,
joining
ma'am.
point of these lines. So no,
Ma'am,
never limit your marking just to that area of scan.
correct, ma'am. And ma'am, what we do, we generally with that plastic cap of the needle, we'll
Correct.
indent
I
it.
saw it. I saw it.
Yes,
And
ma'am.
every one of us, I think, is doing the same thing.
Yes,
But
ma'am.
just extend those lines,
Sure, ma'am.
cephalad and chorded, and also on the both the lateral sides, so that those lines still remain even when you clean your area of spinal or epidural.
Yes, ma'am.
Yeah, good. So one of the advantages of paraspinous approach or the paramedian approach is basically you don't have to flex your patients,
Yes, ma'am.
right? So it's like whenever you rightly pointed out that when we are doing anesthesia for hip surgeries, these are the patients, the positioning is difficult, and in them it's even patients with maybe mild to moderate spine symptoms. You're not supposed to flex them when you do your spinals. So paraspinous or paramedian approaches are very useful in such patients. So never flex the spines when the spine is symptomatic, like suspected, what I should say, a disc or partial disc or some stenotic spines.
Yes, ma'am.
So that is also an indication to go for the paraspinal approach. Anyone else, Anupama ji?
Can I come in? Can I give
Yes,
a
of
comment?
course. Yes, of course, Devesh.
Yeah. At the outset, I would like to congratulate both the fellows for their excellent presentation. And the way you presented it was like some consultant who has been doing it day in and out. And your confidence was very good. So it
Thank
speaks
you.
volumes about the mentors under whose guidance you are working. So I have
Absolutely.
a small comment that in your while visualizing the paravertebral space in the transverse orientation, you said you would be able to visualize superior costal transverse ligament, but you are
Yes.
looking at the paravertebral space from the intercostal view. don't you think ideally it should be called as internal intercostal membrane, which is an extension of superior costotransverse ligament? Because majority of the books still would label it as SCTL, but in my personal view, it should be called as internal intercostal membrane, because that is the lateral extension in the intercostal space. So any comment, any viewpoint, or anybody else who could
Can I come in? Devesh, can I come in? Ritesh here.
Yeah, please.
Go ahead.
Basically, at the level of articular process, we deposit paravertebral at the level of articular process. Okay. If you are depositing at the level of transverse process, then basically it's an internal intercostal membrane. But if you are going slightly down at the level of articular process, then you see the SCTL. Okay, it's a lateral extension. The internal intercostal membrane is a lateral extension of the superior costotransverse ligament. But at the level of articular process, the prick which you are doing to enter the paravertebral space is the superior costotransverse ligament. So obviously you are slightly medial to the place of the internal intercostal membrane, but you don't have to be too medial, because if you go too medial, below the articular process, you have the intervertebral foramina and you have got the arteries there. So that's a danger area. That's a no-go zone. But you have to be slightly medial compared to the internal intercostal. So the prick is of the superior costotransverse ligament.
Okay, I got what you are trying to say. If you are at the level of transverse process, then ideally it should be labeled as internal intercostal membrane. And if we slip a little down a millimeter or 2 millimeter at the level of articular process, you think it should be called as superior costotransverse.
Superior costotransverse ligament.
Okay, thanks for clarifying.
Okay, okay.
Dr. Aishwarya and Dr. Suma, there's a question from Anju Gupta ma'am. Are there any tips to improve success of ultrasound guided thoracic epidural block? Tips to improve success of ultrasound guided thoracic epidural block.
Yes, ma'am. For that, we should be well aware of the how the spinous process overrides one vertebra above and one vertebra below, then the angle of the probe in which we held, and at the angle with which we insert the needle. And suppose if you're hitting the lamina, we can walk over the lamina and we can reach our space, ma'am. So if we follow the sequential scanning as it has been described, we'll reach the space, ma'am, successfully.
Okay, sure. I have one question. Pardon me for joining in the question answer session. We have discussed a lot about the spine scan and how to do the scan and all. My first question is, do you give any, instruction to the patient? And that question is based on the funda that do you do in the preoperative room or just before giving the spinal? What do you prefer? When you do spine scan, where do you prefer? You do in the pre-op area or on the table? And what instruction do you give to this patient? Because I think it matters in spine scan.
Yes, ma'am. What we do on the OT table. We'll explain the patient that we are going to see the back, and we are not, because they are generally anxious patient, that anything touches their back, they'll be very anxious. So what we explain the patient that we are just seeing it on the screen. We are seeing the spine, and whatever procedure we'll be doing, we'll be telling them beforehand, ma'am. And we always have an assistant with us who will be holding the patient, giving the proper position, ma'am. And this helps us in the proper scanning and the labeling.
And regarding the position, do you give any specific instruction?
Yes, ma'am. The patient should be sitting straight with the back little pushed outward and the head down, or we can give a pillow to the patient to hold the pillow in front to have a proper position, ma'am.
Right. And we give an instruction to patient to remember that position, because once we do the scan, we go for painting, draping, and if the patient changes or the technician is overzealous to help us, they might give us some other position, and whatever scanning and marking we have done, if the patient changes his position a lot, then everything will go waste here, right?
Absolutely, ma'am.
Thank you.
to come in. I actually had gone to do an epidural for a 47 BMI patient. I wish we could have taken a video. Just to add to it, excellent presentation from both the speakers and very nice, like a pro they spoke. Madam, regarding your question, same thing. We also take the patient in the OT on the OT table. We do the marking and everything is ready for preparation of the part so that we make the patient sit up on the table with the legs supported on a stool. I usually tell them to sit down and slouch when you feel depressed or low, so that relaxes the back muscles and maintain that position. So we are ready with it because even after painting, sometimes, like you said, if you find difficulty, you can go back and scan it again with carelessly to save time and to prevent all these change in positions.
Yes, ma'am.
Somebody who I think Paravertebral was presented by Aishwarya. Aishwarya, do you do a catheter technique? I'm sorry if I missed it. Or do you do a 2-level, single level? How do you do it? Paravertebral?
Ma'am, we generally use paravertebral blocks for analgesia purpose, ma'am, not for anesthesia purpose. So for analgesia purpose, we give a single level injection, ma'am.
And what are the complications? You've narrated already, I think.
Yes, ma'am.
When you have a patient on anticoagulants, would you like to go ahead with paravertebral blocks?
Ma'am, as we said that we use it for analgesia purpose, and if the patient is on, if an elective surgery, we'll follow the ASRA guidelines, ma'am, because it's a deep block.
So yes, though actually we are on though it's on the ultrasound, the same precautions are to be taken like what we would do for a neuraxial block.
Yes, ma'am. Yes, ma'am. The same precautions we'll take because it's a deep block, ma'am.
When you have a patient with ankylosing spondylitis or a fused bamboo spine, what we call, this was my query and it was very beautifully in some couple of years back. How would you scan and where would you like to look?
In ankylosing spondylitis, ma'am? Sorry. Hello, ma'am, your voice is breaking. Ma'am, can you please come again? Ma'am, you asked for ankylosing spondylitis?
Yes, he asked for ankylosing spondylitis.
Okay. Yes, ma'am.
Am I audible now? Yeah.
Yes, ma'am. Yes, ma'am. It's
so if you say example, you have a patient with a totally fused spine.
Yes, ma'am.
You're unable to enter. You want to scan, and yet you cannot get a window into it. How would you give a intrathecal injection or?
Ma'am, in such patients, we can look for the L5-S1 space, ma'am, because it's a large space, and we can approach from there, ma'am.
Yes, very true, because I tried this and it's beautifully worked for quite a few of my patients because there's one space which is always open. And,
Yes,
of
ma'am.
course, you can't do a thoracic level procedures, but if you need to give spinal, it's a very good access to have.
Yes, ma'am.
Any fellows, if they have any queries?
Hello.
Yes,
This is
Neeta.
Dr. Neeta here.
Go ahead.
Very nice presentation by both the speakers. Really nice. And I also second that. Very good confidence, and it speaks of the work you all are doing. Now, my one query is a single shot versus multi-level paravertebral. Why would you advocate multi-level, and when would you advocate a single shot? Is there any difference?
Ma'am, if you are going for paravertebral block for anesthesia purpose, ma'am, then we would recommend to give at a multiple level injection, ma'am. Or if you're just aiming analgesia, we can go with the single level injection.
So you mean to say the surety is with
Yes.
multi-level?
Yes, ma'am. The
So then
surety will
how
be.
can you guarantee the surety of analgesia with a
Ma'am,
single shot?
Ma'am, with the single shot, actually we cannot guarantee unless and until we scan and see, ma'am. Once we have injected, we can see at what level our drug has reached, then only we can comment on that, ma'am. Because the level of spread is controversial, it is not always same, ma'am, and it's not a multiple level spread. So by scanning only or by some fluoroscopic guidance, if you are using a catheter, then only we can say that till what level it has reached, ma'am.
So according to literature, giving two consecutive, as in if you give it at T2, 4, and 6,
Yes, ma'am.
say for breast surgery example,
Yes, ma'am.
versus giving it at a single space, say T3 or 4.
Yes, ma'am.
There is any literature evidence with regards to the spread?
Yes, ma'am. The spread, ma'am, if you are giving at like the multiple level, the spread will be comparatively more, ma'am, compared to if you're giving it a single level.
But are you aware of septae between two consecutive paravertebral? Is there a continuity always between two consecutive paravertebral spaces?
No,
Are
ma'am.
you aware of any septae?
Yes, ma'am. Like the septa per se, I'm not sure, ma'am, but it's not always continuous because all the acetal ligaments and all, they are intersecting each other, ma'am. So that space gets limited. So suppose if you are increasing the drug volume also, ma'am, we cannot guarantee it will go cranial or caudal. The drug will follow a path of least resistance, ma'am. It will go to medial and the lateral more than the cranial and the caudal. So because of all the septas and the ligaments crisscrossing each other, ma'am, the spread is limited.
Right, absolutely. So there is more surety by giving a multi-level and there are incidences of contiguous nature of two consecutive paravertebral spaces. So for surgical anesthesia, certainly. And for analgesia, have you done any studies to see the spread or have you charted the sensory area of the blocks you all have done?
No, ma'am, we haven't charted the sensory.
Probably that gives an idea of, the actual spread.
Yes, ma'am.
Because analgesia in terms of VAS, of course, it is accompanied with multimodal.
Yes, ma'am.
Right?
Yes.
And have you used it for surgical anesthesia?
No,
At your
ma'am.
center only for analgesia, right?
Yes, ma'am. Yes, ma'am.
Okay. Nice presentation.
Thank you, ma'am.
Any questions from other fellows? Anybody has any queries?
Fellas can add to the chat box also. We will read it out.
Yeah, there is one question. What is the maximum volume given for a single shot block? The paravertebral block.
We generally give 15 to 20 ml, and as we mentioned that even if we increase the volume, there will be more of the medial and the lateral spread compared to the cranial and the caudal spread. So we need not go much higher on the volume. With 15 to 20 or 20 to 25 ml, we can achieve 2-segment up and down block.
Correct.
Yes, for paravertebral block, can we visualize the spread? For single injection, I guess not for the catheter, is the question for. So for single injection, yes, once we have injected, we can visualize the spread. We can actually visualize to what all level the drug has reached. And to decide for the second injection, depending on our surgical area, we can take the call. And for analgesia purpose, like for MRM or such surgeries, 1 level injection for analgesia purpose would be enough.
Yes. That's a good way of deciding whether you need to do a second injection.
Yes.
Can I share my recent experience?
Go ahead.
Yeah, so first of all, very nice presentation by both the fellows. There was some question regarding the Angst font. So L5S1 definitely is the widest space and most often it is the most easily visible, and we used to do the Taylor's approach also when we used to do landmark guided. But recently I tried doing L5S1, though a small window was visible, it was a global kyphosis. But I was repeatedly hitting the bone instead, and I was not able to get into the space. So when I went more cephalad, I was able to locate a paramedian space at T12L1. So I did a kind of segmental spinal at that level. So and the case was done very nicely. The hemodynamics remained excellent. Hemodynamics were excellent, and the patient was absolutely stable. And I just gave a small volume of 0.5 ml hyperbaric to limit the lower limb movements, and rest I gave the isobaric at that level, and the hemodynamics and everything was absolutely stable. So just to mention that this can be one option in our armamentarium in such cases if you want to avoid GA.
Yeah,
What
that's
was
great.
the case, Dr. Anju? What procedure was it?
Actually, it was THR. Most often these patients, they present to us for THRs.
Right.
So we needed a T12 L2 kind of block. And I gave it at T12 L1 only. So not much volume was required.
If we have to use a catheter for post-op analgesia, I think it was Dr. Aishwarya, at what level would you decide? Like, say, because we're going to leave some distance from the tip, right? At what level would you want to put your paravertebral catheter, and what volume of infusion or boluses? How do you want to go about it for post-op analgesia?
Yes, ma'am. The level, like suppose we have to cover, ma'am, 4 segments, then in the middle level we'll choose, and the catheter is generally threaded 1 to 3 centimeter from the needle tip, ma'am. And for analgesia, we generally use 0.2% ropivacaine. We can use at 0.1 ml per kg per hour, ma'am, for infusion. And yes, ma'am.
Yeah. Yeah, that's good. Yeah.
Yeah.
And it would be ideal if we can kind of, tunnel it or something to prevent the migration or pulling out of the catheter. So you can kind of, in a subacute plane, tunnel the catheter if you want to leave it for more than 48 hours.
Yes, ma'am. We can tunnel it, ma'am, and we can use the technique described by Amjad sir also, the flag technique, ma'am. We can do that also.
Is there any literature that bolus is better than infusion for this paravertebral? Because nowadays there's this concept that bolus will be better.
Ma'am, I'm not aware of it. I'm sorry, ma'am.
Okay, one study was done in our setup on this erector spinae plane block, where bolus was found to be better.
Okay, ma'am. I'll go through that, ma'am.
Dr. Sauravi Chaudhary is asking what is the minimum volume to be given in paravertebral block per level in case of multi-level target?
Yes, ma'am. There was an article, ma'am, there was an article by I forgot the name, ma'am. They quoted that per level we can go with 5 ml, ma'am. Like if you're giving multiple level, 5 ml.
Okay, Aishwarya. Any other questions from fellows or faculties?
Yes, ma'am, I got that article. It was by Walid et al. It's an Egyptian journal of anesthesia, ma'am. They have told there that if you're giving, like they have compared one side multiple level and single level. In single level, they used ma'am 20 ml of bupivacaine 0.25%, and for multi level, they gave ma'am 5 ml, 5 ml per segment, ma'am.
Okay, once we finish the class, just share that article on the fellowship group.
Yes, ma'am.
Any other questions? Anupama ma'am, Bharati ma'am?
No, I think we are through.
Any other faculty? Neeta ma'am, Divesh sir, Ritesh sir?
No, done.
Thank you,
With
ma'am.
regards to single level, just to add on 4 to 5 ml if it is each level, but that is usually not required even for surgical anesthesia. So alternating, as I mentioned before, 6 to 8 ml alternate levels should also serve the purpose for surgical anesthesia.
You don't have to give at all the levels. So it's
Yes.
obviously alternate levels. Okay, and it's always alternate, and you can just scan the paravertebral space cephalocaudal and see. You can see the drug spread. And if you are going for a surgical anesthesia, and if you are not happy with the spread at that dermatome, you can always inject that. And regarding angspon, there's a word of caution. If you are not very sure that your spinal is going to work, because obviously L5S1 is a space where the drug, even if you inject, the drug spread sometimes is not at the level which you want. You have to make some modification in your baricity of the drug. So if you are not sure of your spinal, and obviously if these patients, the deformity is so much, the airway will be compromised. So the first important thing is, if you are not sure, secure the airway, better go for a general anesthesia so that you don't land in a trouble once the surgeon has done an incision and the patient starts complaining of pain, then you will land in a trouble. Because these are THR, the patient will be in lateral position, then you are in a mess. So be careful of that. Just a small message.
Rightly said, Ritesh. That is the primary precaution for angspon, definitely.
Good evening, ma'am.
Good evening. Good evening.
One question from Dr. Purva. Any anticipated difficulty in paravertebral block in angspines with encountering the SCTL? Anticipated calcification of SCTL.
I'm not sure about this, ma'am.
Yes, understandable.
Yeah, I couldn't actually understand.
Yeah.
The bouncer to us also.
Yes. I mean, honestly speaking, Aishwarya, you have spoken so much about the spine, and spines and all need lot of experience. So we understand. It's okay.
Thank you, ma'am.
Any more questions, or shall we wrap up the session?
Yeah,
Ritesh?
Just the speakers were very good and confident the way they spoke. It's really nice to hear young people speak like this. So appreciate, really nice. Congratulations.
and excellent videos. Huh? Yes.
Thank you so much, ma'am, and a really heartfelt thank to our mentor, Dr. Ritesh sir and Gaurav sir, for helping us with this.
Great talk. Nice presentation. Keep it up.
Yes.
Thank you, sir.
Best wishes to all of you. Thank you.
Sangamitra, can we wrap up?
So I think so. What about Sangamitra?
We can go ahead with the quiz, sir. Faculty can leave. I will continue with the
Okay.
fellows.
Okay. Thank you, Sangamitra. Thank you.
Thank you, sir. Thank you, ma'am.
Thank you. Thank you.
Fellows, just give me a second. I will just share the quiz. Don't leave, please. Is my screen visible? Hello?
Yes, ma'am.
Yeah. So the quiz is including failed blocks. I have not made a last minute change because it was difficult, and spine itself is a very difficult topic and I didn't want it to push too many questions. So I'm keeping failed blocks also this time. Okay. So next time we will be quiz free, and if you people want a mega quiz because most of your exam going, if you want ki have a club of all the topics to for failed block class, then you let me know, then I will create a mega quiz. Otherwise next time there will be no Kahoot quiz. Today's quiz is actually the questions have been shared by Dr. Shruti ma'am, but since she is a bit busy today, that's why I'm conducting the quiz. Still joining. Shall I start? Which intervertebral level usually offers the largest interlaminar space? Oh, look at the speed. So L5S1 is the largest space, and we should always look for this space, especially when we are having a difficult spinal expected. One should never overlook this space. Let's see. The score depends not only on the correct answer but also on the fastest one. Okay, so Tanu is leading now. Incorrect statement regarding paravertebral block is yeah. It doesn't means that you have put it reliably. It might even go laterally and it might be at the wrongest place possible. Let's see. Oh, Sauravi has jumped in with Tejas. Main purpose of rescue block is? Right, to supplement or correct an incomplete block. Sauravi is leading. Patient undergoing distal forearm surgery. USG guided axillary block was given. Still patient has lateral forearm pain. Most common rescue block here is? Yes, it is the musculocutaneous which needs to be taken care here. Let's see. SUV. Okay. Which of the following is true regarding pharmacological strategy in producing rescue blocks? Yes, because most of the time we know that there is an overlapping of the dermatable and sensory areas. So when you are giving rescue block, you first is to give lower concentration. To calculate the drug amount you have given, we have to take care of the last. And second, most of the time we are just avoiding the sensory effect and to go ahead with the block. So DA is leading. Patient on FNB and PSNB during tourniquet application for ACL surgery. Okay. Femoral nerve block and popliteal-sciatic nerve block during tourniquet application for ACL surgery. Complaints of posterior thigh and knee burning pain. Easy one. Yes, the posterior femoral cutaneous nerve block is needed here. So when Ash and Gauri are leading now. So with Subhajit, I believe, which of the following is an intrathecal ligament? Intrathecal ligament. Many of you got it. It's ligamentum flavum. So Sauravi and Ash are leading. ISB for clavicle fixation, most likely area to remain painful is. Interscalene block is given for clavicle fixation. Supraclavicular and anterior shoulder region. Correct. So Sauravi is leading, followed by Ash and DA. Let's see. Identify the sign. It's easy one. Yes, most of you got it right. It's the horse head sign. Let's see. Saurav is still topping the chart. Compared to an epidural block, a paravertebral block is associated with. Easy one, again. Yeah, lower risk of bilateral block and hypotension. That is why it is preferred. So Gauri is leading now. Which rescue block would best address medial thigh pain after a lumbar plexus block? Medial thigh pain. Yes, obturator nerve block. Correct. So again, Saurav is leading, followed by Ash and Gauri. If laminae and articular process are not symmetrical in transverse interspinous view, what do we suspect? Scoliosis. That's correct. I think both the girls have explained to you a lot today. Let's see. Sauravi, Ash, followed by Sav. It's a very favorite question of examiners, huh? Posterior complex and an anterior complex. Ligamentum flavum and posterior dura. Correct. Let's see the scoreboard. So Ash is stopping now, followed by Sauravi and Sov. Next. Parasagittal longitudinal view at the level of lumbar transverse process. Sign noted as? A simple one. Yes, you all got it right. Trident sign. So Ash is leading, followed by Sauravi and Sov. Which of the following constitutes boundaries of thoracic paravertebral space? Easy one. Yes, vertebral body medially. I think we are on the last question. And Aishwarya, Sauravi and Sov are having a good competition here. Choice of UST transducer in central neurachal block in adult is? Yes, it's a low frequency curved array. Let's see who are the winners today. Gauri in third position. Sauravi second. Yes. The presenter is the winner today. Good.
Avi! Third place! Third place, Mila!
Okay. You can share later on, Dr. Gauri. Okay, so I will close the session. All the fellows, thank you for joining today.